Kular Hospital Private Limited, GT Road, Khanna, Punjab. A trusted brand for weight loss surgery with US certified surgeons having maximum experience in Asia. A certified center for bariatric surgery, Kular Hospital, GT Road, Bija, Khanna, Punjab.
Hello, Dr. Rutledge. Welcome to Kular Hospital. I know it's a difficult time going on in the, this present situation is not very good, as we see the number of COVID cases are going up. And but still it has been, even if it's because of the trouble, because of the problem, but we have had a good time here together. And I think it has been like 6 months, almost 6 months. So we have been in the lockdown.
Yes.
But now, as you see, the practice has started. We are doing some MGBs and things are coming back to track. And maybe it's a couple of months more when we see, the
things will go back
getting,
to normal.
Getting normalized. Yeah. So what do you have to say about your experience about India and this place and about Kular Hospital, as you have been here? You have been coming from last more than 10 years, I suppose.
Yeah.
But this has been the longest period when you stayed here for like 6 months. Yeah.
Well, I would say that what we see around the world is the exciting development of the mini gastric bypass all around the world. And the sad story of that development is the fact that once again I think we're seeing the failure of another kind of weight loss surgery. And you and I have lived through many years of good honorable surgeons doing what has turned out to be a bad operation. That's the lap band. And not to be critical, but I think we can judge by the fact that no one is doing the lap band anymore, is that with kindness and compassion, that was a failure. And so what we know is that operations to try and help people with weight loss can go badly. Now I think we're seeing, and I may be biased, I think we're seeing the sleeve is following the same path. That these blocked operations where they try to create weight loss through a blockage and obstruction lead to poor outcomes. And fortunately, I think for you and I, we are blessed in that, in my own case, for more than 20 years, and in your case, 10 or 15 years.
Yeah.
You have been doing the MGB, and I think that all of us, we give thanks to God every day that our patients, even at the longest time period, seem to be doing well with mini gastric bypass.
Yeah, I must thank God and I must thank Dr. Rutledge because it was like, I think more than I came to you in 2005, I suppose, when you were in Las Vegas, St. Rose Dominican Hospital.
Right.
The very first case which I saw, you did it in 19 minutes. Before that, I was in 12 Oaks Medical Center, Houston, Texas.
Right.
And we were doing Roux-en-Y there. So that would take about 2 hours, 2.5 hours. And you did the first MGB, which I saw in 2005 in 19 minutes. And the patient was sitting in the operation table and walking after 1 hour, drinking liquids within 2 hours. And in the evening when I visited the patient, when I saw the patient, patient was in the private room actually. We were in a habit of keeping the patients in ICU for a couple of days.
Right.
So that was what changed my practice altogether. The concept of too much restriction, too much tightness. Now I understand after 15 years of my practice that we have to see bariatric surgery from patient's point of view.
Yes.
If I make it too tight, patient is not able to eat, because we have to satisfy the brain as well. Satiety, the feeling of fullness, that I'm done. What I have observed, if I say, as a layman, from my patient's point of view,
Yes.
what my patients tell me, especially in Punjab, we are in a habit of eating chapatis,
Yeah,
So
I know.
if we don't eat like 2 chapatis, probably my mind will not agree with me. Mind will say, no, I want more. Probably that was the reason which changed my practice. In the beginning, we started with Roux-en-Ys, 30cc, 50cc pouch. But when I looked at my patient's face, they were not happy, because in Punjab, they want to eat chapatis.
Yes.
And if you cannot eat a moderate amount of diet, you cannot be happy. So with MGB, what I am seeing now, 15 years down the line, when I talk to my patients who are like 10 years, 12 years, 15 years down, they still tell me that they feel satisfied with the same 2 chapatis and some, dal and sabzi, vegetable and some lentil. What I see is that your concept of not too much restriction and a wider outlet, actually it is a low pressure system.
Yes.
And even after so many years, the pouch is not dilating much.
Right.
And the patient is satisfied with a moderate amount of diet.
Right.
And with this T junction, your bypass in the MGB, we know it's the same old Billroth 2 kind of connection. But when the patient is eating into the intestine, and there is definitely something which makes the patient change the eating habits. My patients are not now saying that they want to eat fruits, raw vegetables. That is what, gives them happiness.
Yes.
So probably that change in habit, that you were telling me day before yesterday about the amygdaloid brain,
Yes.
the lizard brain inside our head.
Yes.
That probably changes with MGB. So patient doesn't have to change much. MGB changes you, your habits change, you're not eating much, but eating like almost like a normal person. Nausea, vomiting is way less as I compare with my other patients who I did like sleeve. Maybe I might have done more than 1,000 sleeves earlier. I used to do sleeve in all my young ladies
Yes,
who
we
were
looked at the
unmarried.
data. Yeah,
I used
yeah.
to do single port, but you have looked at the data. But now MGB has changed my practice altogether from last 15 years. Now even if a young lady, unmarried, even if 18 years, 19 years comes to me, I will go ahead with a MGB. Yeah.
Right.
So when you compare Indian system to your American system, as now you have looked into our operation theaters, my practice and post-op care and everything, what do you have to say about the hospital and the practice here in India?
Well, I think that many Americans are biased. We think we are the best, and what I think I've seen in reviewing your data, talking to your patients on a regular basis, is excellence. What we see in your management of the patients, in your results with the patients, in your compassion and the patient's commentary, they are well satisfied. I came with the bias that, everything in America is best. And that I think is one of the problems of America, this lack of humility. But I would say that your practice, amongst the other good ones that I've seen, is superb. And again, you can see it from your own data. We've looked at your outcomes. You have 10-year data on your diabetics, and I think it's worth commenting. What we looked at is your hemoglobin A1C at 10 years, okay? At 10 years, in 100 patients, how many diabetics? I've forgotten the number.
Yeah, the low weight diabetics, about 150,
Yeah.
which we
But
collected
even
the data, yeah.
even the low, the heavy, all of the diabetics
Yeah.
at 10 years have hemoglobin A1C. I think 95, 99% have hemoglobin A1C below 7.
Yes.
Okay, that, according to some of the more recent papers, is declared a success.
Yeah.
Okay, imagine that your data of your diabetics at 10 years has 95% resolution of diabetes. Let me say that again for the video. I apologize. It's such a big thing, and I hope you'll forgive me. We should say it 3 more times, okay? In other words, when Dr. Kular operates on a diabetic, okay, 10 years out, all of the diabetic patients have hemoglobin A1C or less than 7. And if I could, I'll say that one more time, and then say, there are new medicines that you can take for a year or 2, and they show the success rate, even in short term, is well under 50 or 60%, getting to hemoglobin A1C of 7. And they are charging, in US dollars, $20,000 a year, times 10 years, and having less success than your operation done 10 years ago. So I can't emphasize enough, that is giving life over death, complications, blindness, heart attack, stroke, amputation, kidney failure. And imagine that your MGBs are having this result. It speaks overall to success and excellence.
Thank you, sir. Thank you very much for this appreciation and your words. I think it's your procedure, the Mini Gastric Bypass, actually, which you invented in 1997 in North Carolina. So it has not only changed the lives of my patients, it has actually changed the lives of we surgeons also, because we complete the procedure now maybe in 30-40 minutes on an average, and we follow the same anesthetic technique, almost the same anesthetic technique which you were using there, less of relaxants, and in many cases no relaxants.
Right.
And patients are walking within a couple of hours, no indwelling catheters for the urine, and no Riles tubes now into the nose.
Right.
So actually with the MGB, because it's a single anastomosis, the leak rate is like in our series we have had in fresh cases in primary MGBs, we have had 2 or probably 3 leaks out of more than 6,000.
Right.
So I don't know how to put it in figures, like it'll much less than 1%.
Yeah.
So it's a low pressure system. Even the reported late leaks are almost we know non-existent in MGB as compared to the high pressure systems like sleeve, where leaks have been even reported after 1 month, 2 months, and even after 6 months as well. Probably I think the main difference is that you could envisage, you could see that with making a wider outlet, even with a wider outlet, you can have a restriction. And now we understand that it's actually a functional restriction, not an obstructive restriction. So the main difference between MGB and the restrictive procedures is, which I could understand by now, is that it is a functional restriction. Patient is eating into the intestine, and when intestine dilates, it cannot handle too much of food in one go. So patient has to eat small volumes. Patient can eat frequently, maybe 4, 5, 6 times. But if a patient is eating, we discussed it with some of patients also who were complaining like they feel tight and have some pain after eating. If you try to eat too much, you will feel full. So probably it's not the blockade, unlike the band or the sleeve, not a tight outlet unlike a Roux-en-Y. It is a wider outlet of 4 to 5 centimeters, letting the patient enjoy and relish the food. But at the same time, after eating a moderate amount of diet, patient says that I'm done. So this is the main difference which I understand. What do you have to say about this functional restriction and obstructive restriction?
I think it's really very important, and again, I think it's worth emphasizing. Most surgeons and most patients I talk to don't understand the following issue, which is the lap band failed, the vertical banded gastroplasty failed, and I believe that the sleeve is about to fail or is failing. All of these are based on a really simple idea. Let's put a partial blockage. Let's grab a hold of this and cause an obstructive restriction. Because if it's blocked like this, like a roadblock on a busy highway, that blocks the ability of traffic. Okay? But that automatically creates a pathologic eating pattern. It teaches you to eat badly. Because in my slides, I have this up where it says broccoli, no. Apple, no. Sandwich, no. Okay, what goes through this? What goes through this tight, narrow opening? Very simple. Coca-Cola, ice cream, candy, all the worst foods. So even in the initial weight loss, in your study we saw even up to 3 years the sleeve works. But after vomiting and vomiting and vomiting and being sick and being in pain and being crippled by trying to eat into this blockage, they are taught against their will often, and then they blame themselves, or their doctor often blames them for the failure, that Coca-Cola or candy or junk food will go through it. Okay? Now the MGB works opposite. The MGB says, Coca-Cola, you can put it in, I will punish you.
Yes.
We want to punish the patient if they eat bad food, not good food. The MGB induces a healthy response, which is if you drink Coca-Cola, if you drink soda, if you take candy, you get type 2 dumping.
Yeah.
The hyperglycemia followed by the overshoot of insulin and hypoglycemia.
Yeah.
And this is an unpleasant, terrible punishment, so don't do it. Not, on the other hand, to healthy foods. We also notice that the heavy, greasy, meaty kind of foods, oftentimes when they are dumped in, you get type 1 dumping, where the osmotic pressure brings in fluid, stretches like a bowel obstruction pain, and again, the patient is taught healthy choices, so broccoli, yes. Sandwich, small amount, yes. Apple, yes. Ice cream, candy, fried foods, no. And that's the long-term success, and that's what I hear. Now, I would say one more thing, that the MGB is great, but it's like buying a car.
Yes.
If you buy a car and drive it backwards, it doesn't work well. So I have talked to patients who are having trouble with MGB, and I ask them what they are doing. They are drinking Coca-Cola, they're eating fried foods, and they're eating once a day. No. That's trying to drive the car backwards. It's not designed to work that way. And sometimes if they are 10 or 12 years or 15 years and even 20 years in my patients, they may forget. So one of the things that I think is so important is the MGB is powerful, but again, because of its power, you have to know how to use it.
Yes. So small meals, frequent meals, 4, 5, 6 times a day, and avoiding soda pops. And this is something actually which I have seen majority of the patients, they do learn with time because they keep on calling us if they take some high energy drink, some soda pop. After 15 minutes, they have some restlessness, sweating, palpitations. So the heart rate increases. They don't like the feeling. Sometimes we have illiterate patients who don't even know what is going on, but they say we hate these foods.
That's
so,
what I was saying. Forgive me for interrupting, but that I think is really important. What I have found in the past 6 months, because what I've been doing while I'm here is obviously we're doing research, we have several papers coming out, and in addition to that, I've talked to patients. There are many patients, not just illiterate patients, that don't understand why they feel sick.
No.
Again, because it's been a decade, because it's been 12, 15, in some cases 20 years, they forgot that they're feeling sick because they're eating what everyone else eats, which is Coca-Cola, a candy bar, and junk food, and then they say, I've gained weight back, and they're sick all the time. Well, it's easy enough. Turn the car around. In other words, learn that your car goes forward with the front, and you'll do better. So, but again, the MGB is trying to talk to the patient, trying to tell them their illness, their sickness, and their weight gain is ruining their life because they're driving the car backwards. So if anyone is watching this and you're an old MGB patient, call us.
Good, we might help you. You just need to understand how to eat.
Yeah, turn around the car. Right. Call us.
Thank you, Dr. Rutledge. Thank you for being with us. And it has been my pleasure and good luck to be with you for last 6 months here in Bija. I don't want to say that you stay more time because we wish that things normalize at the earliest and you go back to US at the earliest. But still, it has been great learning and a great experience to be with you for last 6 months. Thank you very much for coming to our hospital. Thank you. Thank you for watching.